Thank you very much, Dr. Thani Zhu. That's your American version name, right?
Yes.
Thank you for having me here. And yes, systems medicine, it's a new field of medicine, and the root of it, it's similar to integrative medicine. American Medical Association, they have a group, they call themselves Chronic Disease Prevention and Management, and they come up with a way to take history and physical exam to be more comprehensive, to include all the systems of the body, based on the fact that most of chronic disease are multisystemic diseases. And we find out the specialists, when they are focusing on one system, they fail. Let's say if you have a patient with diabetes and you say, oh, we're going to send it to endocrinologist, right? And what the endocrinologist will do, okay, so they will say, is this diabetic type 1 or 2? So if type 1, they give them insulin. If they're type 2, they give them things that helps to increase the insulin sensitivity, right? Well, this is hypoglycemic drugs. But then if they fail and they're not doing good with it for many reasons, because of the inflammation and oxidative stress, and those hypoglycemics that are not helping anymore, they just give them insulin. And when you give them insulin, actually it's causing more problems, because insulin itself leads to arteriosclerosis, fibrosis, and it stimulates an oxenzyme, generate free radicals, causing more insulin resistance. And then they need to do more insulin. And in fact, that we find out that this way of treatment is wrong. And in fact, they need to go and think about how to increase the insulin sensitivity by looking for all other factors, other systems that may leak, may be inflamed or leaking the free radical generators, such as leaky gut or underlying Lyme disease or toxins. All of this can lead to insulin resistance. So instead of just thinking that hypoglycemic drugs will work, we need to look at other root cause of the insulin resistance, which could be because of patient has leaky gut, leaky gum, patients have underlying chronic inflammation, that patients may have infection, chronic infection. We have to look at all of that and then screen them and then help the patient to detox themselves from all these free radicals, or decrease inflammation, or increase the expression of antioxidants, so that we can increase the insulin resistance. So we need to consider diabetes is multisystemic disease. It's not just endocrinology or endocrinologist, or it's endocrinologic disease. It is also neurological disease. It is also cardiovascular disease, because diabetes can lead to arteriosclerosis and can lead to cardiovascular disease. And so this is the field of medicine that the American Medical Associations are entertaining residency program, fellowship program, where the doctors will be trained to manage chronic disease as multisystemic diseases. Give you an example, we have a neurologist here, and if I ask her how to manage Alzheimer's, she will say, okay, Alzheimer's is because of neurodegenerative of the cholinergic neurons. So they have low acetylcholine. So we give them inhibitors of acetylcholine to increase acetylcholine, and that will help acetylcholine esterase to increase acetylcholine, and that will help to increase the cognitive. But if we think about the root cause of the neurodegenerative of the acetylcholinergic neurons, it's because the problem with detoxing from amyloids, right? They have amyloids, trash of amyloids in their brain, and they build up, and that causes degeneration. It induces inflammation, oxidative stress, and it leads to degeneration. So instead of just thinking about giving them acetylcholine esterase and not thinking about the root cause and slowing the process of neurodegenerative disease itself, by looking a way to decrease all the other free radical generators that's coming from leaky gut, that's coming from underlying chronic infections, coming from the toxins, and consider all of this accelerate the neurodegeneration, because you are causing more oxidation and adding to the oxidation of the problem with the neurons of detoxing from amyloids. And also, if we think about how we can break the amyloids using curcumin, methylene blue, all of this may help to stimulate the autophagy, or the turnover of the amyloid, and possibly preventing it from happening from the beginning. So we need to consider the root cause instead of giving the treatment, the symptomatic treatments. And how we approach those chronic diseases. We approach them based on pathophysiology. And I think I define chronic disease as a new medical specialty that focusing on managing chronic disease by modulating four things: redox, metabolic, immune, regenerative. Those are four pillars. That is most of the chronic disease. That's the pathophysiology of most of the chronic disease is redox imbalance or immune dysregulation or metabolic problems or regenerative problems, right? And when you talk about regenerative problems or regenerative imbalance, I'm talking either degeneration, where they have problem of growth or regeneration, or we have abnormal growth, which is tumor. Both is under regenerative status. And that is the regenerative status of the patient, is whether it's degeneration or abnormal proliferation, which is the tumor. And so by understanding this four pillars of pathophysiology, we can manage chronic disease more effective, more efficiently. Add to that the genomics behind it. So we can say immunomics, metabolic, metabolomics. We can consider regenerative genomics, right? And redoxomics, which the underlying genetics that regulate all the pathophysiology of those four pillars that we talked about. Now, because American Medical Association is entertaining this field of chronic disease prevention and management, and it is another name of integrative medicine or holistic medicine. There's another field that's called systems medicine, which is the same thing. It's treating the disease by considering all the systems of the body, not just focusing on one system, because you will fail if you manage it through one system. And also, when we manage oncology, we need to also consider those four pillars as well. Because cancer is not just abnormal growth of the tumor, but also it has other drivers that cause the cancer to grow. What is other drivers? It could be metabolic, which is, for example, you have patients with fasting insulin high, right, with diabetic type 2, or even before having even diabetes, you have patients with normal hemoglobin A1C, normal glucose, and they have high insulin, high fasting insulin. And that high fasting insulin is an mTOR stimulation. It can stimulate the growth of the tumor. So high insulin is one of the drivers of the cancer. It's metabolic, right? And so that's why we need to look at fasting insulin and lower it in order to prevent cancer from happening, because constant high insulin stimulates mTOR, that can drive into the cancer. Cancer also, yes, it's genomics, genetics, mutation, and SNPs, but without the right environment, those cancers will not emerge. But with the right environment, whether it's metabolic, high insulin, or immune dysregulation, right? So patients have chronic inflammation for some reason, maybe having chronic infection or having high insulin. High insulin itself can compromise the immune system. How? They modulate the immune system and shifting it more into Treg or Th2 and Th17 from Th1 and cytotoxic T cells. We know that cytotoxic T cells and Th1 are the immune surveillance. So anything that causes dysregulation and shifting of the immune system away from Th1 and cytotoxic T cells, it can lead to cancer. High insulin is one of them, but other reasons, other drivers of chronic inflammation, toxins, infections, genomics that has to do with causing inflammation. The other thing is that if you have mitochondrial dysfunction and you have abnormal and redox, or you have toxins in your body like heavy metals, all the petrochemicals, all those microplastic, those are free radical generators. And too much of free radical, constant high free radicals can cause mutation and can cause what? Can drive to cancer, right? Insulin itself, high, can stimulate the NOx enzyme, generate free radicals that cause the environment of mutation, and if you have genomic SNPs that leads to cancer, it will activate it and lead to cancer. And so we need to look at all of those four pillars when we manage the cancer, and we need to also think beyond what oncologists do. What oncologists do when they manage cancer? All they think is to destroy the cancer. But us as integrative oncology, we're not just thinking about destroying the cancer, we also want to change the tumor and microenvironment to be a hostile environment of the cancer. Because cancer secretes chemicals in favor of the growth of the cancer. What is the factors that favor the growth of the cancer? One of the biggest things is fibrosis. And think about that. If the cancer secretes chemicals that leads to fibrosis, the fibrosis squeeze the blood vessels and prevent the infiltration of the immune cells to go in, right? What are the things? Why are we failing in oncology? Because fibrosis squeezes the blood vessels, preventing red blood cells from going in. So you have what? Hypoxia, right? And if you have hypoxia, you have acidosis. And hypoxia, if you're trying to treat patient when he has hypoxia in the cancer, we treat them with radiotherapy. What radiotherapy do? It increases the free radicals, right? But if there's no oxygen there, there's no free radicals, right? And then they squeeze the blood vessels to the point even your chemotherapy cannot go in. Your immunotherapy cannot go in. Your immune systems cannot go in. The other thing is that they secrete chemicals to modulate the immune system and push them away from cytotoxic T cells and Th1. They move them into where? Into Th17 and Treg, right? Which goes in neutrophils. What neutrophils can do with the cancer? I need cytotoxic T cells. I need Th1. I need natural killer cells to kill the cancers. So the cancer shifts the immune system from what kill the cancer into immune inflammation like Th2 and goes in mast cell activation, or it goes Th17 and interleukin 6, which goes neutrophils. What this can do to kill the cancer? Nothing. But this is how the cancer is evading, by causing your immune system. And yes, you have inflammation, but what kind of inflammation? Inflammation that does not destroy the cancer, but actually promote the cancer. So when we are thinking about destroying the cancer, we need to consider not just destroying the cancer itself, but also changing the tumor microenvironment by breaking those fibroses, using sonication, using antifibrotic drugs, by shifting the immune system into Th1 and cytotoxic T cells, by giving drugs that inhibit Th17 and Th2, right? And what those drugs that inhibit Th17 and Th2 and all that, like thymosin alpha, it helps. Ivermectin, drug that helps to inhibit. Anything that modulate the naltrexones, anything that modulate and push your immune system to Th1 and cytotoxic T cells will help in managing cancer. So we are changing the tumor microenvironment to be what? To be aggressive against a hostile environment against cancer, but also we need to optimize the whole body health. We need to look at all the toxins in the body and detox them, because this can cause more inflammations and compromise your immune system, right? You need to, if the patient has overweight and insulin resistance, you need to manage that as well, because insulin itself will stimulate the mTOR and drive the cancer. And so this is what we call systems oncology, which we are, in addition to destroying the cancer by chemotherapy, radiotherapy, and immunotherapy. And if you give them immunotherapy and they have fibrosis, your immunotherapy will not go into the cancer. So it's useless, right? So you need to break down that fibrosis. And so in addition to killing the cancer, we need to change the tumor microenvironment to become a hostile environment, and also we need to optimize the patient's health in general, looking at all other systems of the bodies and making sure all the systems of the body is healthy and working, and optimize them, increasing performance. All right, so is that right? We go next. Which one? This one? Okay. No? I missed this one, right?
No. This one.
Oh, this one, okay. Good. So, here, again, cancer is a system-level disease, right? It's not a single pathway. The oncologist and even the genomics, we have a doctor here in genomic medicine, we say cancer is mutations, SNPs, and genomics, right? But we hear a lot of people outside in the media that, oh, cancer is metabolism, is due to eating sugar, and other will say cancer is because if you have immune suppressed, then you have risk of having cancer. So yes, it's a combination of everything, right? It's not just genomics, but also it's environmental, it's toxins. Yes, you have a background of genomic SNPs that leads to cancer, right? But also the environment and the health of the host also determine whether those genomic SNPs will turn into cancer or not. And good that we have genomic medicine or doctor here to tell us, oh, this patient has high risk of having cancer. So what we will do, we try to optimize his health and find out exactly what those genomic SNPs, and looking for all the nutrition and things to optimize his body to prevent triggering those genes to become cancer, right? So it's a combination of yes, molecular or genomics problem. If you see here, those are genomics, the PIK3CA, those are genomics that the genomic doctor here, he can go ahead and screen that and say, hey, those patients may have risk of having cancer. Yes, it's genomic instability, but what causes mutation? The free radicals, the chronic inflammation can cause those mutations or can trigger them more and can lead to cancer. So it is immune dysregulation. We know patients with HIV, they have cancer because their immune is being suppressed. Your immune surveillance is being suppressed. But not just HIV, patients with high insulin, right? Also, they are immune compromised because insulin polarizes the immune system away from natural killer cells or inhibit the natural killer cells, the cytotoxic T cells, the Th1. So you need to lower the insulin to protect those patients from having cancer. All right, and then we have the cancer itself, right? How they survive. Let's say they escape the immune system because the immune system is being compromised, your immune surveillance, right? So how they survive, how they grow, okay? First of all, cancer does not grow inside environment of oxygen because what would happen, you have the mitochondria is functioning and then this will lead to mitophagy and kill the cancer. So what would happen is that the cancer will start secreting chemicals, suppressing your mitochondria and rely on glycolysis to produce oxygen. And say, hey, I don't need a mitochondria, I'm gonna suppress it, right? And they rely on sugar. And also on glutamate. If people say, okay, well, you know what, I'm not eating sugar, the cancer can adapt and say, I'm going to eat glutamate instead of sugar, right? So it's very tricky, it's very intelligent. And so they are using all the tricks, right, to prevent the mitochondria from causing mitophagy. Mitophagy is a way to destroy the cancer. And the cancer is suppressing the mitochondria and say, I don't want it to blow me up. So I'm going to suppress you and I'm going to rely on glucose to build up my ATP. And so this is how cancer is doing things to survive the apoptosis and mitophagy and killing by suppressing the mitochondria. So what we will do is to activate the mitochondria. The other thing, they secrete chemicals to induce fibrosis. And fibrosis prevents red blood cells from carrying oxygen into the cell. And if you don't have oxygen, you don't have the mitochondria function, right? Because mitochondria works on oxygen to generate ATP, right? And so cancer does that because he does not want too much of free radicals. He doesn't want the mitochondria to blow up and release cytochrome oxidation causing apoptosis. So he's doing everything to suppress the mitophagy by hypoxia, by fibrosis, preventing the red blood cells from going in, and also relying on glucose, right, to produce ATP. I don't want the mitochondrial energy, and I can rely on sugar, right? And that's why we recommend patients to do fasting, low carb, to starve the cancer. But the cancer can adapt and say, I'm going to take glutamine as well. So you need to find glutamine foods, and you're trying to restrict it from it as well. And so the cancer is changing the tumor microenvironment for them to grow, whether through fibrosis, hypoxia, abnormal vasculature. What about cancer? They will say, oh, cancer is highly vascular. So how come you say it's hypoxic, right? Anybody think about this? I need you doctors to think. Well, they are highly vascular, but their vascularity is abnormal, it's kinked. So think about the hose. You have many hoses, but they're kinked. And when you're kinked, what will happen? You get the glucose, you get the nutrition, but the kink itself, the kinking blood vessels, the abnormal vasculature, there are a lot, but abnormal, they will not allow what? The red blood cells from going in. They will not allow the immune cells to go in, right? They exclude them. And this is how the cancer can grow, right? So it's very smart. Yeah, and cancer, I need sugar. I don't want oxygen, so red blood cells, I'm going to restrict it by producing blood vessels. Yes, bring me nutrition and glucose, but no red blood cells getting oxygen and no white blood cells because those blood vessels are going to be kinked. So they will have high vascular but abnormal that is hypoxic, and a lot of doctors would think high vascular, and how come it's hypoxic? Well, because it's abnormal and kinked, and they are not allowed the red blood cells getting oxygen to go in. So what we do to overcome that, we put them in oxygen chamber, we give them ozone as integrative oncology. And we are kind of complementing the mainstream medicine. We're not, so chemotherapy, radiotherapy will not work without oxygen. We say, let us give them oxygen and ozone to help to activate and generate free radicals caused by radiotherapy and chemotherapy, right? And so we have a center, it's called New Medicine in California, joined force with Dr. Canelli, and this is what we do. We are helping the oncologists through integrative oncology protocols that we're doing to help those patients to optimize their health and work mainly on tumor microenvironments. And then if the oncologists fail and they say, hey, we're done with you, you're gonna die after 3 months, they come to us and we try to improve their quality of life, possibly help them to eradicate the cancer using our approach, our integrative approach, which include not just destroying cancer, which we do with low-dose chemotherapy, loaded with platelet nanoparticle, targeted therapy, activated with light, breaking down the fibrosis with sonation. We give them antifibrotics. We give them a lot of things that will help to prolong their life and possibly eradicate it, and then optimize the whole health of the body, looking at the tricks of the cancer, how they are evading the immune system, how they are preventing oxygen from going in, activate the mitochondria, reversing what all the tricks they do to survive. This is very important to manage cancer. So you cannot just manage cancer by destroying it, but also by making the tumor microenvironment, hostile environment, and also activate the immune system, right? With your immunotherapy, anti-PD-L1, anti-PD-1, anti-CTL4. I don't know if you know about those, but those are immunotherapy that helps to activate the immune system against cancer. Why? Because the cancer, when they have cytotoxic T cells, they're trying to attack it. The cancer itself has a PD-1, and they inhibit the cytotoxic T cells and turn them off, right? And then you have also the macrophages, which is M1. When you have the Th1 and they're trying to be activated, the macrophages, which is M2, sorry, or the M-reg, they inhibit those cytotoxic T cells through CTLA inhibitors. So what we need to do is to inhibit those CTLA by giving them CTLA inhibitors, and if you do that, then you activate those lymphocytes and cytotoxic T cells and Th1 to become aggressive against cancer. All right, so cancer must be understood as a system disease, right? It's not just killing the cancer, but also changing the tumor microenvironment. And changing the tumor microenvironment involves all the systems of the body to be optimized, right? Giving them antifibrotic, modulate the immune system, trying to shift them to cytotoxic T cells and natural killer cells, and activate your immune system, and inhibit the Th17, Th2, Treg, and also breaking down the fibrosis. And other problem we have is acidosis. What would happen when the mitochondria and the cancer does not work? What would happen? Then you have glycolysis. What would happen to glycolysis? You have lactic acid. Build up lactic acid leads to acidosis. What acidosis does in the cancer? First, it stimulates more transforming growth factor secretion and fibrosis. Second, it turns the cancer cells into cancer stem cells, which is very difficult to get away from. De-differentiation to cancer stem cells. What are the things they do? It shifts the immune system from Th1 to Th2 and Treg, and it inhibits cytotoxic T cells, the acidosis. So we need to prevent that acidosis. How we do it? By activating the mitochondria, by allowing the oxygen to go in, by breaking down the fibrosis, allowing the red blood cells getting the oxygen in, or giving them ozone or oxygen therapies, right? And all of this will help to activate the mitochondria, lower the acidosis, right? And if you lower the acidosis, you can reverse all these problems. The immune become more powerful to destroy the cancer. And when you break the fibrosis, you allow the chemotherapy to go in, your immunotherapy to go in, and if you allow that, all this blood going in and oxygen go in, the mitochondria will be function, and you can have enough oxygen to generate free radicals, which we needed for the chemotherapy to work, or radiotherapy to work. So it is very important that integrative oncology approach needs to be integrated with the mainstream medicine oncology approach, protocol, which is chemotherapy, radiotherapy, and all the things that they do in order to enhance it. We're not negating it. You don't give, for example, reduced glutathione and reduced vitamin C to patients taking chemotherapy, because this will reduce the free radicals that you need to destroy the cancer. So it's very important that integrative oncology, they don't go and become very extreme and giving things that negate the chemotherapy. Then you will upset your oncologist. Because the oncologists say, I'm generating free radicals, and you're giving them reduced glutathione or reduced vitamin C. No.
But you can give high oxidized vitamin C to generate free radicals, which is through stimulation of generation of the free radicals, which is hydrogen peroxide, yes, but not reduced vitamin C or too much of antioxidant, which negate the free radical generators produced by chemotherapy and radiotherapy. All right, so we need to understand the cancer. We need to learn all the tricks of the cancer, right? How they are tricking us, how they're evading the immune system, how they're producing fibrosis and how we can negate it, acidosis, how we can shift the immune system to kill the cancer. And if we do that, then we can definitely help to destroy the cancer. All right, so the idea about the chemotherapy cocktail, how we manage cancer. We have a cocktail of chemotherapy specifically for that cancer, right? And everybody, let's say for breast cancer, they have cocktail of chemotherapy. Everybody has to take this cocktail of chemotherapy. And most of those cocktail of chemotherapy, they target one pathway or two pathways. And that's it, right? So what will happen? You have a problem there. What's the problem? When you give them a cocktail of chemotherapy, think about it, not everybody responds the same. Because of what? Because of genetic variations. So now today, what we do, we say we don't want to do any more of this cocktail. We need to test it. Give it to the genomics doctor, and he will test it, whether this are sensitive to it or not. And if not, give me the cocktail that is sensitive to the chemotherapy, list of chemotherapy that's sensitive, and I will receive that cocktail of chemotherapy, right, knowing exactly what, and then give it to the patients, right? So now it's called personalized oncology, which I have a book there, right? And also Dr. Canelli has a book there as well about managing cancer by integrative approach. So we take this cocktail based on the genomics, and then we give it to the patient. Are we going to give it to the high dose? No. I think it's better if we give the low dose, targeted inside a nanoparticle, like latest nanoparticle, so we can get it into the cancer versus going everywhere. And this is called targeted chemotherapy. Low dose targeted chemotherapy. Not just that, we can activate the chemotherapy using light and using sound. Activate them inside. Even chemotherapy. We also use photosensitizers, right? To activate them with light as well. We call photodynamic therapy. And we can use sound, which is called sonodynamic therapy. And we break down the fibrosis by histotripsy or shock wave that's strong enough to break down the fibrosis. We need to use all the tools, not just the classic chemotherapy which failed. Especially if the tumor, okay, you got me all this destruction, the tumor is destroyed by chemotherapy and they shrink. And this inflammation that is produced by chemotherapy, most of it is TX17. And also, tumor itself secretes chemicals from this inflammation or from destruction that cause the immune system to be shifted and to TX17 and TH2, which compromise your immune system because you don't have much of cytotoxic T cells anymore. So what would happen? Those tumors, they become more aggressive and they become insensitive, and then they start producing fibrosis as well. And then fibrosis squeezes the blood vessels, preventing those chemotherapy that the oncologists are giving. Think about it. They shield themselves. Like my dad, in the beginning, when I give them chemotherapy, photodynamic therapy works. And you can see the methylene blue stains his tumor. But then what would happen? Yeah, and the radiotherapy also shrink the tumor, but then I cannot stain it anymore. Do you know why? It becomes white ball of cancer, of fibrosis. Squeezing the blood vessels, even methylene blue cannot go in. And when I look at it, it's not staining. Why? I don't know about fibrosis before. So one of the reasons of failing of the oncologists today is cancer-associated fibrosis. And we need all to work together in finding a solution to break cancer-associated fibrosis. Whether chemically we can give it, losartan is one of them, sonication, things that there's many other drugs that's antifibrotic to break the fibrosis, opening up the blood vessels, getting the chemotherapy to go in order for us to win the battle with the cancer. So that is exactly what happened and the reason why the oncology failed, right? Because first of all, those chemotherapy that we're giving is not being tested against that patient, and the patient may have genetic resistance to it, and that's why we have to have a genomic study finding out exactly the list of the chemotherapy. And what would happen, let's say the chemotherapy that is working and then shrink and then stop working. Why? Because you block one pathway or two with the drugs. But because the cancer is mutating, what will happen? Those drugs will not work anymore, and they will mutate and find another pathway to override the pathway you blocked. And there will be another mutations, right? And so you're chasing a ghost. It's like, you have a bug and you give them a spray. In the beginning they die, and then they say, hey, if you want to spray more. Because why? They have resistance. One of the resistance they do, they build up a transport. They kick the drug of chemotherapy out, right? Efflux. And so that's the reason if the drugs is entering to the cancer through transporters, we can overcome that, override that by endocytosis, by loading the drugs into a pack of liposomes or pack of lattice nanoparticle and entering the cells by endocytosis. In that way, we bypass this efflux of the chemotherapy and the resistance. So using lattice nanoparticle loaded with chemotherapy, or exosomes loaded with chemotherapy from umbilical cells, or liposomes, liposomes, they use it for doxorubicin, and they call it Doxil. And you use lower dose, but still the Doxil not for liposome is a problem because liposome is considered chemical that your macrophages can see it as a foreign and they intercept it. So what's the best thing to use is use your own platelets, nanoparticles. Break down the platelets into platelet lysates, or break it down into release its exosomes, right? And then load them with drugs using sondication. We're doing that in our clinic there in New Medicine, and I invite everybody to come there and see what we're doing. And then you go ahead and inject them in a package of platelets nanoparticle, and you're going to go ahead and target it with what you activated with photo or sonodynamic therapy. All right, so basically all the rest of the slides is going to talk about the same thing, is to look or manage the cancer not by thinking about breaking it and killing it, but also look at the tumor microenvironment and make it hostile to the cancer, because the cancer is doing everything to change the tumor microenvironment for the cancer to grow. And you need to know all those changes they are doing and work on reversing it. And all those changes, whether it is fibrosis to prevent red blood cells from going in, oxygen from going in, and compromising your mitochondria, compromising the mitophagy, and then the cancer to grow, or by compromising your immune system, shifting it away from cytotoxic T cells and natural killer cells, and producing inflammation that is not going to kill cancer, which is Th17 and Th2 and Treg, right? Or producing abnormal vasculature that will allow the glucose to go in, but they're kinked. They're not allowed the red blood cells to carry oxygen, or the lymphocytes to go in, or they squeeze the blood vessel. Even chemotherapy cannot go in. And we don't have oxygen, hypoxic, your radiotherapy won't work because you need oxygen to generate free radicals. You need oxygen for chemotherapy to work. And so I think the oncologists need to work with those intelligent integrative oncology in order to optimize the health of the body, in order to turn the tumor microenvironment to be a hostile environment to the cancer, in addition to kill the cancer, but kill the cancer with list of chemotherapy that's being studied by the genomics, finding out what chemotherapy will work. Use low dose chemotherapy, load it inside lattice nanoparticle, activated with light, activated with sound, break down the fibrosis, right? Giving the patients everything that helps to break the fibrosis. There's a lot of antifibrotic, or giving things that helps to activate the mitochondria so you can induce the mitophagy, and giving things that helps to lower the acidosis by activating the mitochondria, or the cancer stem cells. There's lots of pathways that the cancer stem cells that you can get rid of. There's drugs for cancer stem cells, and one of them, which is mebendazole, will help to interfere with the microtubules, which we use it for meiosis.
Halasa, you have 2 minutes.
Yeah, and helps to get those cancer stem cells to grow. Mebendazole is one of the drugs, but there's many other drugs that works on the Wnt pathway and may help to get rid from the cancer stem cells. So understanding all the tricks of the cancer, including the cancer stem cells, including that acidosis, including everything that the cancer is doing to make a tumor microenvironment in favor, trying to reverse it and make it hostile, in addition to optimize the health of the whole body of the patient using integrative or systems medicine protocol. Thank you very much. And if there's any question, you're welcome.
I have a question. Do you agree that cancer is a system? Yes.
What is that?
Cancer is like a system.
Cancer is intelligent creature that is compromising your immune system, They're using all the tricks to evade the immune system and grow and suck your nutrition and prevent the free radicals from inducing apoptosis and killing them and grow and replace the host. That's what's and they're intelligent. Whatever you do, they try to find a way to bypass it. Whether drug that you do, they mutate another way and they overcome whatever blockage that you're doing with your chemotherapy. So it is an intelligent creature, and managing it, you need to work on the whole systems optimize the whole systems of the body, optimize all the, reverse all the pathophysiology of the cancer, especially the tumor microenvironment. And if you do that, you turn the tumor microenvironment, hostile environment to the cancer, you also destroy the cancer, you optimize the health of the body, right? Patient is what has cachexia, because cancer secretes chemicals to prevent you from eating, and when they have cachexia, what will happen? Malnutrition, they don't eat, yeah? Your immune system suppressed. That's what they do. They want to suppress the immune system. So you need to work on increasing. Also, you need to increase their muscles. Muscles is very important to increase. The reason why, because how I can get rid from acidosis? Exercise will clean up those lactic acids, right? And exercise will build up the muscles where it will lower the insulin, right? Because you see all those patients with cancer chemotherapy, your fasting insulin is very high. Why? Because those chemotherapy is also causing insulin resistance, causing insulin to be high. Insulin itself will drive the cancer from all different directions. Stimulate the mTOR, stimulate the fibrosis, it stimulates the inflammation, stimulate oxidative stress. It leads to compromising the immune system. So fasting insulin, it's very important to be optimized. It has to be less than 5 for everybody. You know, 70% of the adult population here in America, they have high insulin, driving inflammation, driving immune compromising, driving tumors. And we need to go ahead and work on lowering their weight, because high fat leads to insulin resistance. Why? Because fat means interleukin-6 and inflammation. Inflammation means free radicals, oxidation of the insulin receptors leading to what? Insulin to be high, and the insulin will start compromising the immune system and cause all this cancer that we see all over. In addition to all this microenvironment, the petrochemicals that you live inside. We're living inside a bubble of petrochemicals, right? Plastics, all those glyphosides and all that stuff. All those are free radical generators. And all of this can be a driver of the cancer. Any other questions?
Okay, yes, thank you. It's a nice topic, and definitely I have a question. And as you can see, I already introduced myself. I also do cancer research. So that's an interesting talk, and at least I can follow and understand some key concepts which I'm familiar. So you talk about cancer stem cells. Yeah, we do have some. I also do some cancer stem cell research previously. You also talk about the tumor microenvironment. And then one thing is interesting, you noted about oxygen therapy, which can reverse cancer progress. So in this case, we focus on oxygen therapy. For the tumors, cancer, the standard way we know, operation, surgical operation to remove the cancer mass, or the chemotherapy, or the radiotherapy, like some standard way. But for oxygen therapy, I know, I did some also, say, 20 years ago, not updates that, but in Chicago, University of Chicago. So I'm familiar about cancer associated fibroblasts. We do have some. Actually, it's very difficult to isolate and culture in vitro in the lab, like a manipulation. So we do not have publication on that, but we do have practice about CAF. So then the question is it efficient about oxygen therapy in cancer?
I think it's just one way to getting the oxygen going to the cancer, because cancer is excluding red blood cells from going in by fibrosis and leading to hypoxia. And if you have low oxygen, your mitochondria will not work. And if your mitochondria does not work, you compromise one of the important way of blowing up the tumor, which is mitophagy.
Yeah, we know there's a hypoxia in tumor microenvironment. So then,
right.
How to introduce, in my English, how to introduce the
so we have the oxygen,
exogenous oxygen
right.
to the tumor microenvironment to increase the the concentration of the oxygen in tumor microenvironment. Technically, right. how to reach this goal.
So we do it, so basically the blood vessels being squeezed by the fibrosis, and also because of the too much of VGF, vascular endothelial growth factor, the blood vessels is growing but abnormally kinked. So this all prevent the red blood cells from going in, carrying oxygen, leading to hypoxia. So what we want to do, okay, well, can we increase the plasma oxygen concentration? How we can do that? By putting him in an oxygen chamber, the oxygen will dissolve in the plasma, and you don't need the red blood cells, and that one way to get the oxygen in. But at the same time, you need to really think about breaking the fibrosis, right, by using histotripsy and using sonication or antifibrotic to open up those blood vessels, right, to break down the fibrosis. And also, maybe you need to give something that blocks the VGF, like Avastin, to normalize those blood vessels again, right? No, not more anymore kinky. So all of this, whether you're giving oxygen or breaking down the fibrosis or normalizing the vasculature, all this approach is to get the oxygen inside the cells, whether through red blood cells by opening up those blood vessels, or by dissolving more oxygen to the plasma, where you don't need the red blood cells and it gets more oxygen there. So oxygen chamber, ozone therapy, things that we do, integrative approach, all of this would help to get the oxygen into the cancer.
Okay.
And maybe possibly injecting the tumor with ozone.
Okay, thank you very much. Basically, I understand the approach what you're talking about. A very interesting topic. I think because of the conference time is limited, and we spend our morning in lecture and oral presentation. So Dr. Halasa will be last to speak. For platform presentation. So I'm going to give you a certificate, and someone is going to give a photo for us. Now it is time for diploma for you. I'm kidding.
Thank you very much. I
It's
appreciate
international
that.
diploma from.
Thank you.
Yeah, Dr. Kwan.
Don't forget to send it to me.
Yeah.
Okay.
Yeah, definitely.
Let's see. Camera. Yeah. 1, 2, 3. Yeah.
Okay.
Good?
Thank you.
Thank you very much.
Now you have.
Now I'm officially pimped.
Shall we take photos for?
Oh, yeah, for the group.
So
now,
we take a photo together. Let's photo together.
Yeah,
Let's photo
okay.
together.
With
We try
this or
to-
without it?
Sorry?
Okay.
Yeah.
Okay.
你帮助我们这个这个 photo。
整体拍照还有
这个但是一对一的话什么那个都可以。
OK。
我们先拍集体的吧。
好
先拍集体的。
咱们先把它打一打。
那你过来。
来
你就在我的左边嘛，你就在VIP 的右边嘛，其他的都过来。
好，一起照相，一起照相。
我也可以照。
你是我的助理，过来。对，那你就站边上嘛。
OK，我站边上。
看看是两边的人，看看是。
因为左边有一个人走，你就负责这样就对，你就站边上去。
挤一下，再挤一下。
要挤一下，稍微记得a little bit close。
对，你好像你
不
用过了
你自己站近一点。
不，你让他站好好吧，这样。
先让他们在中间点，对，可以。
还是不行，再挤一下。
再挤一下，实在不行就几个小女生要等
围着下，
再不行就先围一下看看，可以吗？
在桌子后面
吃饭。
你往后一点就行了。
你去那边。
往后一点。
我们往后一点
他不能往后了，咱往后，咱们往后一点。
人太小，那个先别由他定，是我们移还是什么？
这样可以，但是女孩子。
那边一个也靠近一点，稍微侧一点嘛，对不对？
对，现在就可以了。
Ready？
好 来，还有一个，
阿罗哈的什么这个？对这个。
阿罗哈
对呀，这个看。
对，再来一个阿罗哈的这个，阿罗哈的文化。非洲吗？
是呀。
对。
No, that's it.
Aloha.
This one? Okay, I'll go with this one.
都可以。
Doesn't matter.
开吧
OK.
Go ahead.
We don't. OK.
好
Good.
行，然后要单独这个，你们这。
来 OK，到了，开始。
哦不，I think first I need to pick up.
OK，
你稍微等一下，对，我
那
就您来吧，用您的手机比较熟悉。
OK。
对，我们还是把这个
对，
能把这个标志的放进去就放进去啊。会长要找这边来一点。
来，我们三个人，来，可以，让我们三个人来。
好，我们张会长啊。
然后我跟张会长聊这一个，其他我就不管了。
好，1, 2, 3。
等下我跟我的助理在这个。OK, now is my turn. OK,
Alright,
yeah,
you're
yeah,
done.
Yeah. 然后会长这一个。
稍微朝这边来一点。